Happy Monday, and today we're going to be talking about joints. So, why do we want to talk about joints and study joints? What are some things that joints, she's going like this, hi-ya, right? Joints help us to move, right? So move is a big one. Move is the easy one. What's another thing that joints help us to do? Where else do we have joints?
They hold some bones together.
To help hold bones together, protection. Perfect example is the joints in the chest plate, right? They move a little bit because what do we have to do with our ribs? What do our ribs help us to do? Breathe. So there has to be a little bit of movability, but do we want a lot of movement here? No. We want to protect our mediastinum or our chest area and our lungs because they're very delicate tissues. All right? And we do that with the bony thorax connected with those costal cartilages that help to join to the sternum and provide a little movement. Okay? What can go wrong with joints? They can become inflamed. This is a huge problem in our society. So we can either damage a joint. How many athletes do I have in here? And how many athletes do I have with damaged joints of some sort? Right, most of you, right? If you're an athlete of any sort, you're probably gonna end up damaging your knee, your hip. I've been taking my kids skiing and I feel every old injury that I've ever had when I ski with them, you know, because you're putting impact on those joints and eventually they're gonna get damaged. I'll go through how they get damaged in a little bit. So, you're going to be dealing with many patients who are going to have issues with their joints. The other thing that's important about joints, I don't know how much I go about it in here, but this is an important sidebar. One of my family members, I can't tell you who, but I'll say a family member, keeps falling. Okay? And he keeps falling because he hasn't taken care of his joints. What happens to a lot of elderly as they age? What happens to their posture? Right? They get really stooped. This is going to put an abnormal stress on your joints. But in addition to putting abnormal stress on your joints, you also can't be aware of where you are in space as much because we have little receptors in our joints that tell us where we are and how we should move. And as you get older, if you don't work on your balance, those receptors don't function as well. There's whole physical therapy regimens that can be put into place that can teach you how to balance better. So you don't have to be old and frail. You can work against that. I'm just saying, a little sidebar. That's definitely taping, right? Can you look and see is the red? Mm-hmm. Okay, great. All right, so joints are more than just connectors. They function to help us, excuse me, work better in our space and our environment. Okay, arthro means joint. So arthroscopy would be a study of the joint, right? If a surgeon's going to go in and take a peek around. So these, I think, you know, point and shoot kind of stuff. So synarthroses are immovable fibrous joints. Can you think of an area where we have fibrous joints? The skull. Okay. So over time, we'll have those fibrous joints that join together, right? And they're immovable. Well, why don't we just start with one bony skull? For those of you who have me for that.
They wouldn't go through the birth canal as easily.
That's right. They wouldn't go through the birth canal as easily. They also wouldn't grow as easily, right? If you start as a little bitty bony skull, where are you going to grow, right? Nowhere. So we start the nice solid skull as multiple bones, so it can grow as we get older, and so it's easier for the birthing process. Once they ossify completely together, then they're immovable. All right? Does that make sense? Amphiarthroses are slightly movable. I just talked to you about the cartilage that connects the ribs to the sternum is a good one. So that's slightly movable, okay, but not fully movable. I always thought like an amphibian could be on land and water. It could be two things, right, is how I remembered that. These are cartilaginous joints. Good morning. Diarthroses are freely movable. And I'm going to show you all the parts of those diarthroses, because guess where we damage most of our joints? In these. Because if there is more movement, there's obviously going to be more activity in that joint. It's going to be more prone to being injured. There's also structural reasons I'll show you. Any questions on that, on those classifications? Okay, so fibrous, cartilaginous, synovial. So fibrous, cartilaginous, synovial. I don't even know why I put them separately. Okay. Okay. Fibrous joints, as I said, between the skulls, there's no joint cavity. What's in a joint cavity? Does anybody know what that fluid is called? It begins with an S.
Synovial.
Synovial fluid. So these don't, right? These will have bone growing right up to bone, and then some fibers in there to help mesh them together as well. Okay? Sutures of the skull. Syndesmosis, that's actually like a ligamentous connection at the distal end of the tib fib. Okay, I don't go over that the whole time. Gomphosis is peg and socket. It's what you see with the tooth. I don't go over much of that as well. What I really focus on is sutures as an example of those fibrous ones. Cartilaginous joints. We have synchondroses, we have symphysis. So synchondroses are held together with cartilage. Those are your growth plates. Symphyses are pads of fibrocartilage. Do you remember when we talked about the 3 types of cartilage? I said pads or discs are made of fibrocartilage. So if you look at them microscopically, they have certain characteristics. Okay? So a good example would be like discs of the spine or the pubic symphysis for these. Okay? I hear you. Tired today too. Okay. Synovial joints, movable, covered by that synovial fluid. We see them where the ends of long bones meet together. Could be in the fingers, could be in the extremities, could be the legs. And they have very specific characteristics. They have that synovial fluid in that joint. What does that synovial fluid do you think? It's a cushion. In addition to being a cushion, it also helps to provide nourishment and nutrients. Good. Okay. We have a joint cavity. I'm going to show a picture of all of these things. The joint cavity basically surrounds that entire joint to keep that fluid in. We have articular cartilage, which is a cartilage on the ends of those long bones. Do you remember what that cartilage is made of we spoke of last week? Hyaline cartilage. Okay. And then always, there's reinforcing ligaments across that joint to make it even stronger. Any questions on any of that? So taking a look, where is that in the body?
Shoulder.
Your shoulder, very good. So it'll be your, what bone is this? Your humerus, how it articulates into the what? I hear it, scapula, okay? Now, the thing to start thinking of with joints, when you go in and look at the big skeleton in the lab, you'll look at this joint and it sits into the scapula. The head of the humerus will sit into this fossa, okay? But it's fairly shallow. Okay, are you with me? And I'll tell you where I'm going in just a minute. It's fairly shallow. Do we have a good range of motion with the shoulder? Absolutely, very big range of motion. Now, if you think about the hip or the femur and how the femur sits into the acetabulum, it's a much what connection, or it's much deeper. Why would it be much deeper? I'm doing it right now. Weight bearing. It makes a more solid foundation for where the femur sits into the acetabulum or the hip bone. Are you with me? Okay. But back to the shoulder. Since you have such a range of motion and it's shallower, you have less stability. And with less stability, we tend to have more what in the shoulder? Injuries. Okay. Do we still have injuries in the hip? Absolutely. Okay, absolutely. Are you with me? But these two joints tend to be arthritic because they take so much wear and tear, right? Take so much wear and tear. Okay, so let's look at these parts of the synovial joint. Can you see it okay with the lights on, or do you want me to turn the lights off for a couple minutes? You see it okay? Lights off for people in the back? Okay. Excuse me. Is that better?
Yeah.
Okay, great. All right. So, what happens is, remember that periosteum, okay, comes down and it'll sort of transition into that articular cartilage on the ends of the bones, right? And that cartilage will be the areas where they would butt up against each other should they touch, and it provides a cushion for that joint. Also coming off that periosteum, we have ligaments, and then we sort of have this joint capsule, which you can see like this light green kind of wraps its way around and provides a nice little enclosed space for that synovial fluid in that joint. Are you with me? Does that all make sense? Okay. And then surrounding that joint capsule over it from bone to bone, we're going to have reinforcing what? What connects bone to bone? Ligaments. Tendons connect muscle to bone. Ligaments connect bone to bone. Now, you might have tendons that cross the joint as well. That can happen. But our primary supporters for the joints across that joint are ligaments. Are you with me? Does that make sense? Okay. Okay. Any questions on this? Just grab my phone out here. Okay, great. So, Bursa and tendon sheaths. Does anybody know what these are? Yes, they're fluid-filled pockets. I was wondering if you knew about them because we get what of them?
Bursa.
Yeah, we get bursitis and tendonitis. Okay. What these are, which you could actually get an inflammation of the tendon itself, but the sheath would be inflamed as well. What these are is little fluid-filled pockets, or the bursa, let me start with bursa first, that are put in areas where you have higher wear and tear. If you look at the shoulder joint, and they give you an example of some of these bursa here, like where the humerus comes in, we actually have the acromion, which is the top of the scapula, right above it. So we have this little bursa there to provide some cushion so those bones don't constantly push up against each other. Because that's not where the joint is, you understand, right? Even though it's bone to bone, okay? They just happen to be next to each other. So those bursa provide a little bit of, and there are several of them in joints, a little bit of cushioning, okay? And then when we talk about tendon sheaths, they're exactly the same thing, except they go around a tendon. They wrap right around it. Remember I gave that analogy with myelin of the croissants wrapped around the hot dog? It's that same kind of formation. I don't know, I made a weird analogy. And that very important one is going to be where the bicipital tendon comes down. It'll wrap around that and it provides protection. Okay? Good. Any questions on that? So if you add an itis to the end, the inflammation of that, either bursa or tendon. Okay. All right, so movement of the bones. I'm not going to go over flexion, extension, rotation, all those things. I might just talk about one or two of them. And why am I not going to go over them? Because it's super easy, okay? So obviously, as we go through them, if you have a question, raise your hands. I'm going to explain one or two of the movements, but most of them I'm going to let you do on your own because it makes sense. The one thing I am going to talk to you about, and I put this in this lecture for a couple of reasons, is how muscles move bones, okay? And the reason I put it in this lecture is because muscles must blank to move a bone. They must contract. There's another thing I'm looking for. Cross a joint, right? If I take my bicep muscle, somehow magically attach it just to my humerus, the two ends of it, what's it gonna do? Maybe do the, we were at Saranac Thursday years ago, and there was a guy that his t-shirt said, sun's out, guns out, right? And you could see it, and he was like, you know, trying to, did you see that guy too? No, okay. Oh. Right, sun's out, guns out, because he likes to flex his biceps, and maybe that's the only thing that you could do is just maybe flex it if it were connected to the same bone, right? But it's got to cross a joint to move that joint. All right. Now, I never think you should wear t-shirts that talk about yourself. You know what I'm saying? I'm just saying. Why, do you have that t-shirt? Is that why you're laughing so hard? Okay. Okay. All right. So, oh no, did you think I said something in it?
No.
Oh, okay. All right. Woo. All right. So anyway, back to the muscles crossing the joints. All right. So they got to cross the joint in order to move the bone. Right. So let's talk about the ends of the muscles. Now I want you to listen to me. Just listen to me for just a second. This is one of those things. It just is what it is. Don't make origin and insertion of muscles a big thing. I'm going to give you the definition, you're going to memorize it, you're going to be done with it. Okay, it just is what it is. So basically I think of the origin of a muscle as being the beginning, the insertion being the end. Okay? The origin, let me just see which part of the board she put up for me. Excuse me. Okay. Oh, here we go. All right. Origin and insertion of muscles, okay? So we already have in the notes that the origin is immovable, the insertion is movable. So if you look at me for just a second, my biceps starts about here in another spot, and it inserts here. So what does your biceps do to your arm? Right? This is the movable part of the biceps. Are you with me? So this is the origin, it's immovable, the insertion is movable. Do you think there's exceptions to that? Absolutely. Okay, there's exceptions. You'd actually fix this and use this to move it. We're not going to look into that. What I'm telling you for the purposes of this class is the origin's going to be immovable, the insertion will be movable. Why is it that way? Because it is. Candy for lab, he knows. Because it is, right? Okay, this is one of those few times where you just can't make it make sense. It just is what it is, okay? Are we clear? Okay, so immovable, movable. Now, the locations of the origins and the insertions. I want you to look at me and listen for just a minute, and then I'll write it down on the board, okay? If the muscle goes up and down on the arms or the legs, the stomach's an exception, so let's not even worry about it. The origin is closer to the body, which would be more what? Proximal. The insertion is further from the torso, that would be distal. Easy peasy. So for my quads, the origin would be where? Here. The insertion would be here. For my shin muscles, which we're going to get into next week, that's why I'm not naming them, the origin would be here. The insertion would be where? On my foot. Are you with me? Does that make sense? So muscles that are up and down, origin is going to be proximal, insertion will be distal. Okay? So for vertical muscles, origin will be proximal or closer to the trunk. The insertion will be what? Distal or farther, whoops, from the trunk. Why, Alex? Because it is. People get so confused about origin and insertion. It's really just simple. That's it. Okay? But if a muscle, well, it's not quite it. If a muscle is horizontal, okay, the origin is more medial, the insertion is more lateral. Are you with me with that? Pretty much it's just pecs. All right? So, if a muscle is horizontal, the origin will be medial on the torso. Excuse me. The insertion will be lateral, usually on the arms. Why? Because it is. So pec muscles, the origin's here, the insertion's here, it moves the arm in. Okay? All right, does that make sense? And as you start, you're gonna have to go through and do a whole chart of muscles and their origins and their insertions. We'll give them to you in lab so you can start working on them, okay? And you'll have to know the origins, their insertions, and their movements. Now let me preface that. There's over 600 muscles in the body, and I think I give you like 40 or 50. Okay, so I do pare it down even though it doesn't seem like I do, but I do. All right? Okay, so any questions on muscles? Origin and insertions has to cross a joint. We understand if it's vertical, where the origin and the insertion is. We understand if it's horizontal, where they are. Correct? Are we good with that? Yes? All right, good. So movements, like I said, I'm going to buzz through them really quick. Flexion, extension, I think we got that. You do need to read through it though to understand what it is per joint. Flexion of the knee is going to be different from flexion of the shoulder, okay? So make sure you look through and you understand that for each joint. Abduction and adduction I do want to talk to you about because I think it's a little confusing. I say AB or AD according to which one I'm talking about, okay? Can anybody tell me what abduction is? Yes. So abduction is moving away from the midline. So if I move my arms out, I'm abducting them. If I move them in, I'm adducting them or adducting them. And people always remember it because you're doing what to the arms? You're adding them to the body, right? Same thing with the legs, adding them to the midline. Okay, are you with me? Abduction, adduction. Yes? Okay. That was a little confusing. One second. So medial circumduction is making a circle, rotation is rotating around a joint, okay? Lateral and medial rotation, or I call it internal, external rotation, is a good thing to know with the shoulder, okay? So external rotation or lateral rotation, internal rotation or medial rotation. Why is that a good thing to know, do you think? I'm just going to keep doing this until somebody answers. What do you think you as a healthcare professional should know? What do we do to shoulders? We dislocate them, right? We dislocate them. You need to know the motion of that shoulder. When they go to set it, they'll put it into internal rotation to set it. Okay, so it is good to know internal and external rotation of the shoulder. You guys, should I get espresso this morning? Are you guys like having a tough morning? Everybody's so quiet. Is it just that point of the year? Yeah, it was like, All right, so internal, external rotation is good to know with the shoulder. Okay, and the same thing would be for the hip, internal, external rotation. Okay? Now, supination and pronation. I never use this for the foot, supination and pronation. I think your book did at one point. Let me tell you what I want you to use for the foot, well, I should say the ankle, okay, is inversion. And what does inversion do? Moves the foot in. Eversion moves the foot out, okay? So inversion moves the foot in. I don't know if you're gonna be able to see that on the recording. Eversion, and it's up here. Eversion moves the foot out. Has anybody ever twisted their ankle? Okay, it's important to know if it's an eversion or an inversion sprain. What do we most likely do when we sprain our ankle? Do we roll it out or do we roll it in?
Pull it out.
Actually in, it's much weaker going that way. If you were to see the ligaments on the joint, they're much thinner on the outside. There's a big thick one on the inside. So people tend to roll in like this, like that, okay? It's important to know which way your patient rolled their ankle because then you know what's damaged. You have a better idea of what ligaments are damaged, right? Whether they're on the outside or the inside, okay? Does that make sense? Supination and pronation. Have you heard of this one? Does it sound familiar? You'll need it if you're in healthcare for placement of a patient. A patient can be placed either supine, which means on their back, or prone, which means on their stomach. Okay, so we're all aware of that. We also have supination and pronation of the forearm. An easy way to remember that, pronate is face down. If you hold a bowl of soup, you turn your hands face up. Supination, okay? Now it could be this way too. Supination, pronation. It doesn't have to be, don't think because I'm saying a bowl of soup, right? Supination, pronation, okay? But I think most likely you'll hear it with the placement of patients, whether they're face up or face down. All right? Protraction, retraction, I think that makes sense. Elevation, depression, mandible, that makes sense too. All right? So, what time is it? Let's do a quick 2-minute break. All right, so types of synovial joints. Types of synovial joints. There's really only one or two, I think just one that I really want to focus on, but let's go through these types of synovial joints. Excuse me. So they all have the synovial fluid in them. The difference in this list, and it's kind of a point and shoot list, I'm going to go through it quickly, is the shapes. Okay, this first one is a plane. The plane joint is flat, so they almost slide across each other. All right? Excuse me. A hinge joint is just like the hinge of a door. Okay, we see this primarily in the elbow joint, where you have a round surface and a convex shape that fits around it. Okay, a hinge joint. So plane will slide, that hinge joint will bend well in one direction, okay, more or less flexing and extending. I'm sorry,
That
what?
was an elbow.
Elbow, yeah, for the hinge joint, not the plane, right? Plane we find in the carpals. Pivot joints have a ligament wrapped around them, excuse me, and they can create a rotational movement. Condyloid has this really funny, like almost round ball shape and then a cup that fits around it, okay? We find that in the finger joints. So obviously I'm going through these quickly, so this is just the little bit that I want you to know about them, okay? Yes?
Where do you find pivot points?
Pivot joint is going to be in the elbow, where the radius and the ulna connect together. And that's what that picture is of.
What is the condyle?
Condyloid is going to be found in the fingers. And you could see from this picture, it's almost like a cup that accepts a similarly round shape into it.
How does a pivot joint move?
How does a pivot joint move? Like this. So the pivot joint, which is going to happen between, or have we all learned all the bones, hopefully radius and ulna, will allow this pivoting, this pronation and supination of the joint. Any other questions on these? Good. Okay. Saddle joint is going to be just like a saddle shape. We'll see that at the base of the thumb. Excuse me. Ball and socket is really the joint that we're going to focus on, okay? I think I talked about the parts of the hinge joint as well, okay? I know I buzzed through those quickly, it's just because they are what they are. But I mean, do you have any questions about them? Okay, so ball and socket will be a nice round head. Do you have a question?
Is your shoulder?
Yes, it is. It's just more shallow than the hip. The hip is so obviously ball and socket. The shoulder is as well, it's just more shallow. Okay. All right, any other questions about those shapes?
Is your knee also?
The knee would be, no, because it also slides. Your knee, the reason you have the ligaments in the front and back is to check the sliding motion on the knee itself. So I think it'd be a little bit of a hinge, but also a plane. There's also some pivot with the fibula. So it's gonna be a combination of things. That's why I don't want to say I don't care about these definitions. There's somebody looking at, I turned the camera on, right? I'm always gonna ask, okay.
Where else did you find pain?
They'll be between the carpals and also between the tarsals. Because quite often with a joint, you're gonna have a somewhat combination of things happening, so. Right, any other questions about those? I do want to show you specific joints, which I think is almost more important, okay? The knee joint has multiple structures which help to reinforce it. I tried to draw lines. I know it's hard to see them. This is one of the few times I'm gonna say pull it up on your computer so you can actually see that picture, because I took time to draw the lines, but of course the lines are white, you know? Or you could draw the lines yourself onto your notes if that helps you. But I go over the knee joint and all its specific parts because we have a lot of injuries in the knee. First of all, because we're walking on it. Second of all, we don't walk properly on it. We have people hit them. If you're an ice hockey player, you get whacked in the knee. If you're a field hockey player like I was, you get whacked in the knee. Okay, there's a lot of issues with our knees as we get older. Plain old, excuse me, walking can be an issue, okay? So let's look at these structures. I'm gonna go right in order. So we have the femur comes down and it sits into the tibia itself, okay? Have you learned those? So the femur would be the thigh bone, the tibia would be this shin bone, and then what do we have on the lateral aspect? Your fibula, okay? That is a non-weight bearing bone. Why do you think we have the fibula there?
Support.
Supports what?
The tibia.
By helping to attach what to it?
The femur.
You're on the right track. What do you use to tie them all together? Muscles and tendons. It provides another site of attachment for muscles and tendons in that region. So even though it's not weight bearing, it does provide a function. Okay? But the weight bearing portions will be the femur and the tibia. When you look at the tibia, there's two flat planes, and then you have points which come up in the center, all right? And then you have the two ends, of the femur will sit right down into them, okay? And at that point, you'll have these two menisci. Now, it's important to understand, which is lateral and which is medial. The way you always tell it's lateral is by the what? What's your surefire answer? The fibula. So the meniscus that is closer to the fibula will be the lateral. The one that is on the other side will be the medial. And these menisci are little C-shaped discs of cartilage, okay? believe they're fibrocartilage. And what do you think that their main purpose will be? Yeah, just to cushion that knee joint. As people get older, if they have wear and tear in their knees and it gets really progressive, they can wear a lot of those menisci down or even away or rip them. We can tear them. That's what happens when you hear people having meniscus damage. They've gotten a little rip in that meniscus. But guess what? It's a pretty simple surgery. They go in and they'll shave that little rip off, or they'll suture it if it's too big, and the patient will be functional. Will they be as good as new? Not really. Usually once people have that meniscus surgery, they have some more issues with their knee. Okay? So menisci. Does that make sense? Yes? Okay. Patellar ligament. So moving down. They have this cut away, you understand. Usually this would be up, right? Because your patella is your what? That kneecap. And the patella has a tendon, a ligament, which wraps around it and then turns into a tendon. So if you imagine this is back up, that tendon then comes up and attaches to all four what muscles? Quadricep muscles. And they're named quadricep because there are four of them. Okay, we'll go over the four separate quad muscles in lab. So can you envision that? Okay, below the kneecap you have a patellar ligament. Above it, it turns into the patellar tendon because now it is attaching that bony patella to the muscles. People get confused about that. Does that make sense? Okay, so patellar tendon is above the patella. Patellar ligament is below the patella because it connects the patella to the tibia. Yes? Yes? Yes, yes, yes? Okay. Can we get problems with the patella? Yeah, absolutely. I saw a girl dislocate her patella. It's awful. And it tends to pull up and out. And it will just sit there until it's put back into place. Okay? All right. So, fibular and tibial collateral ligaments. So the book is now calling it fibular collateral and tibial collateral because it connects to those specific bones. You will absolutely hear lateral collateral and medial collateral ligaments. I would memorize them both, especially if you're going to be in emergency, trauma, orthopedics, because as old people, that's what we learned. And we use what we learned. Okay, so lateral collateral will be which one? Fibular. Medial collateral will be tibial. Are you with me? Okay. And their job is to prevent the knee from going side to side too much. So how would we damage that or injure it?
When the knee goes off to one side or the other.
And more than going off to the other side, when you have think of ice hockey players. When they get some sort of blow right to the knee from the side, it can damage that ligament. Okay. All right. So now we have the menisci. This also is a synovial joint. We have the synovial fluid in there. We have the joint capsule. We have the medial and lateral collateral ligaments. Okay. Two more ligaments we're going to talk about. Anterior cruciate and posterior cruciate. These probably will sound familiar. Has anybody damaged these? ACL. Does that sound familiar? Right, this is it. Anterior cruciate and posterior cruciate. Why do you think they call them cruciate? They cross. They look like a cross. And anterior cruciate is here. Posterior cruciate is here. It's a little hard to see. The anterior cruciate would be like this. The posterior cruciate would be like this. They're named and how they attach to the tibia. So anterior cruciate crosses and attaches anteriorly on the tibia. Posterior cruciate comes back and attaches posteriorly. Are you with me? Okay. What they do is they stop the femur from sliding on the tibia. This is why if you see a football player and they're running and somebody stops their shin and their femur keeps going, they probably are going to tear their anterior cruciate if they're going to damage anything, because that anterior cruciate slows that movement. The reason we tear it more often is because that's the way we're running, right? But also the posterior cruciate not only stops the movement backwards, but how your femur locks into the tibia stops it from going too far back too. So it has more support in stopping the femur from sliding backwards. The anterior cruciate's kind of a one-man show with that slowing of that movement. All right, does that make sense? That's why we see so many injuries to that ACL. Can they surgically fix it? Yeah, are you ever the same? Not really, unfortunately. All right, so those are the cruciate ligaments. It's a lot, it's jumbo, but this knee is important because a lot of people damage their knees. Now, not only can you damage these structures, you could just get plain old arthritis. I had a patient years ago who literally, bless you, femur was right on her tibia. Just worn most of those ligaments and cartilage and synovial fluid and just bone on bone. And that's when they have to go in and they take everything out and put a new one in. It's not easy, but it's wonderful what they can do. Okay? Any questions on those structures? Okay, cool. Shoulder, lots of movement, less stability, more injuries. Okay? Now, it's supported by ligaments. I don't get into a ton of them. What I do talk to you about, and we'll really talk about more of this in lab, excuse me, are the rotator cuff muscles. Okay? The rotator cuff muscles, their abbreviation is SITS. I'll go through those SITS muscles in lab, okay, specifically. The rotator cuff muscles are what hold your humerus into your scapula. If you think about this skeleton for a minute, and if you can't envision this, go look at it in lab. The only bony attachment that your shoulder girdle has to your torso is right here at the sternum. So it goes sternum, clavicle. Clavicle attaches to your what? Scapula. And then your scapula works together with your humerus. So it's a very unstable joint. It only has one bony articulation to your axial skeleton. What helps to hold it in place is the rotator cuff muscles. Okay, and we'll go over those when we go over them in lab, and we'll tell you them specifically. Now, they're called rotator cuff because guess what they do? They rotate the shoulder, okay? All right? There's one or two that are very small and weak and they tend to get damaged, and that's why we have so many shoulder problems. Because of their placement, all the stress that are put on them. Okay. You have a couple bursa in there as well that help to cushion that joint. All right, any questions about that? No? Okay. Hip joint. Much deeper than the humerus. It's supported by several strong ligaments, several strong muscles. We'll talk about the muscles when we get into naming muscles. I don't really make you memorize any of the ligaments, but I do want you to know there's a lot of very strong ligaments in that area that help to support that joint. Once you know the specific names of the bones, you can kind of figure out where the ligaments are. If you go into orthopedics, you'll probably have to know them. But there's also a lot of strong muscles which cross that joint to help support it. The main stability comes from the depth of that joint. Okay, so with the elbow, we've got the biceps and the triceps which cross that joint that help support it and move it. It moves in inflection extension, we know that. I wanted to talk about these bursa. You can see there's a bursa which actually wraps around the end of the humerus, and there's one behind the elbow. The reason I want to point that out is because you can get an awful bursitis. I've seen it several times behind the elbow. And I mean, this happens to my father, which I don't know if I'm breaking hip up by talking about my dad or not. But I mean, it'll swell out to here. That's why I wanted to bring that up to you. You might see it, it looks awful. Is it? No, but what do they have to go in and do? They have to drain all the fluid from it, okay? So I just want you to be aware of that bursa behind the elbow. There's also one behind the knee. And the reason I bring this up, clinically speaking, is you also have what artery behind the knee? It's a pulse point, excuse me. What is it? No, what's the one behind the knee? Popliteal or popliteal. Go back and review your pulse points if you don't know them, please. All right? Now, popliteal is right where that bursa is behind the knee. So what might we have a little difficulty diagnosing if we see something swollen back there? Bursitis versus clot or swelling in that popliteal artery. So if you lightly put your fingers on what you think is bursitis and you feel it pulsing, what are you going to do? My God, guys, you're going to call somebody as soon as possible, right? It could be an aneurysm of his popliteal artery, right? Okay? If you touch something and it's pulsing ever, out you go, right? You need to be seen immediately. That's your carotid artery. You're fine. As a matter of fact, you can see mine so much if I go like that, you can see them. So don't get nervous now. No, don't go home and go, oh my God. Like, you know, and start feeling all these pulses. Okay? Just a differential diagnosis, because there is a nice big bursa back there. Could be a Baker's cyst. I think it's the name of it. Baker's cyst bursa. Bursitis, okay? If it's pulsing though, leave it alone, okay? Dear God. Oh, Lord help me. Okay, so common joint injuries. Oh, this is awesome. Okay, we can get started on muscles. Sprains. So sprains, by definition, are injury to a ligament. Strains are injury to a tendon. Okay, so sprains, ligament, strains, tendon. Okay, both of them, ligaments and tendons, are not well vascularized. What does that mean? There's no arteries and veins going directly to it. It gets all of its nutrients by diffusion, right? So if you strain or sprain something, does it heal readily? No. It's usually a long process, depending on how badly you injured it, okay? Cartilage. Does cartilage have a lot of blood supply? No, same thing. Does not have direct blood supply. So if you injure it, guess what? Either you're going to live with it, or you have to have it surgically fixed, okay? One or the other, depending on how bad it is. It's pretty neat if you get it. I mean, it's not neat to talk about people's injuries. The surgery is neat to watch when they go in and they clean that joint out, okay? One thing that I mentioned here with this cartilage is you could rip it and it might still be in place, but you could get something called a loose body, where that cartilage can completely rip off, and what does it do? Floats around in that joint. So is that going to be like consistent pain from that patient that's going to seem the same every time they have a flare-up? Or is it going to seem different? What do you think if it's floating around in there? Yeah, it's going to be different, right? One day they'll be like, oh, it's killing me, and then they get a big pop. That's kind of fine for a while, and then it happens again. Or it gets loose enough and buried enough they don't feel it at all, okay? Those are called loose bodies. And this would be removed arthroscopically. Dislocation. I've done a ton of stuff in my life. Dissected cadavers, seen minor surgery, saw people, tap fluid off of joints. Guess what freaked me out the worst?
Walking on top of
Oh my God. And it was fingers. This girl came in with a finger like that. I can do anything except for fingers, dislocate a finger. And guess what they do? Oh, it's awful. I shouldn't even tell you. They're like, oh, here, let me just bam. And you're like, right? Okay. So anyway, do you think her finger was ever the same? No, as a matter of fact, it was the second time that it happened. And fingers are exceptionally tough because you can't, I guess you could get little barbells and do little push-ups and stuff, right? But how do you rehab that, right? Shoulders you can. Shoulders are not as obvious. I can actually pop my shoulder out. I won't do it anymore because it aggravates it. But shoulders, you'll just see it slightly decrease. And if you have somebody who's really good, they'll just manipulate it and it'll go right back in. Or they'll just hang you down off a table with a weight, and that's enough to kind of reset it. Shoulders you can absolutely, and you should absolutely rehab, because if you don't, it'll keep popping out, okay? I mean, you could do toes, you could do fingers, thumbs, patella. I saw a young lady with a dislocated patella, which was like awful. And the EMTs insisted on cutting her pants open. Like, you can see it through the pants. But anyway, she was looking at me like, can you help me? I'm like, but anyway, so all of them have to be reduced, right? They have to be put back into place, and then you've got to rehab them so they're healthy again, okay? And what happens, why they become weak, is because you stretch or tear the ligaments or the tendons that support them, okay? So will you fix those ligaments or those tendons? Not necessarily, but you can strengthen the muscles around it, and it helps greatly. Inflammation, let me tell you, mark my words, famous words of Dr. D, inflammation is the basis, you don't need to write this down, but you can if you want to, of the majority of our diseases in our society. Mark my words. Arthritis, heart, all the damage to the inside of your blood vessels, throwing clots, it's all inflammation. And the diets that we have in the United States with all the weights and the sugars, pro-inflammatory, and I think this is why we have so many problems. Oh, do you guys, are you big white bread eaters? You just looked at each other.
We had a lunch movie for another class.
Oh, did you? Which class?
Writing.
About
It was, food and anything about, it was just different movies about,
health.
yeah.
Yeah, it's frightening. So stress, not exercising, all leads to inflammation. So this can damage our joints, and I'll talk about some of those steps, but I'm telling you, it's also damaging brains, it's damaging cardiovascular systems, and that leads to damage everywhere else. So try to think about your health and what you're eating and doing, okay? Back to joints though, we can also, excuse me, just damage the joints themselves. We can get bursitis, tendonitis, which we spoke about, which I think makes sense. Arthritis, so there's different types of arthritis. I want you to understand this. Regular wear and tear. So all of us who are athletes who used to run a lot get regular osteoarthritis. And what that means is, I fell on this hip 20 years ago. It damaged the structure of that joint. There tends to be more stress on that joint. I tend to have more inflammation in that joint. Okay, osteoarthritis. Now, that is very different from rheumatoid and gouty arthritis. Those are systemic problems. Do you understand what I mean by systemic? There's something wrong with the whole body, okay? With rheumatoid, it's an autoimmune. Did we go over that last semester? Autoimmune? Maybe, maybe not. Let's go over it right now. Auto means what? Auto means like self, right? Autoimmune means your tissues are attacked by your own immune system. When you're born, your immune system sends cells out that sort of sniff out all your tissues. Okay, that's mine, that's mine, that's mine, that's just like a dog, right? That's mine, that's mine, that's mine. What happens when your dog smells something that's not it? It's not it. You know what I mean? Pees on it. That's what your immune system does, right? It finds cells that it thinks are not its own cells, and it will attack it with immune complexes. It doesn't pee on it. Okay? Are you with me? Okay. It goes awry. For some people, their immune system starts to, and it could happen with other things. It could happen in the kidney, it could happen in the muscles. For some people, those immune system cells will come out and attack the joints. This is known as rheumatoid, okay? And it has a very, I think I have a picture of it in the next slide or two, specific pattern that it presents with. But basically, rheumatoid will start damaging and destroying all the joints of your body. Unfortunately, it's a very sad disease. And the problem with treatment is what the, does anybody know what the only treatment is? Immune suppressors. So you put these poor people on immune suppressors and then they're constantly sick, right? So it's kind of a very difficult disease that we haven't really figured out how to treat yet. Gout. Okay, gout is a joint disease where you have a problem processing certain proteins. And you can't convert them and get them out of your system, so they basically turn into these little crystal structures that deposit into your joints. They like to deposit into joints that are furthest from the torso and the coolest, so they start with the big toe. Okay, and gout will present as red and inflamed because you basically have these pointing crystalline structures within the joint itself. Okay, and then it can affect the ankle, can become more proximal. Okay, so gouty arthritis is because of that problem with the metabolism of proteins. All right, let's move on to, give me 2 minutes, we're gonna move on to muscles. All right, we are now going to go over as much as we can